Welcome and thank you for joining our fireside chat discussion around leveraging data to address health inequities in our communities. Again, my name is Dr. Hassanatu Blake, and I'm thrilled to be your moderator today. We have a really great discussion planned, and as many of you know, we are living in a pivotal time where we have made great strides around data analytics, and healthcare. We've been able to change the way we collect information, the way we analyze information, and also, more importantly, the way we share information around health data. However, many of these strides are not necessarily seen or reached into our different communities. And we know that many of our communities suffer from a lack of access to healthcare, predatory outreach, and also different types of health outcomes based off of the lack of data that's actually being shared or collected. But we have a terrific panel here today. These distinguished panelists will talk a little bit about evidence-based health equity approaches to addressing some of those inequities. Today's discussion is really about being able to take action and spark action using data so that we can advance health equity. After our conversation, we will open the discussion up to all of you. So we really want to hear your questions so that the panelists can respond to them. So without further ado, I am going to hand it to our panelists to introduce themselves and then quickly share with you all their commitment to this important work.
Okay.
Dr. Glenn.
Good morning, everyone. I'm Dr. Clyde Edward Glenn. I'm the president of the Essie and William Earl Glenn Foundation for Better Living and the ACEs Awareness Foundation of Mississippi. We like to define ourselves as a sibling-inspired, family-focused, community-based organization. And if my sister Helen has her way, she would tell me to emphasize that we're also place-based, and we do evidence-based work through precision medicine as well. Our mission really is to create thriving communities by eliminating barriers to children, families, and youth.
Excellent.
Great. Good afternoon, everyone. We're before lunch, so you know that you're going to be awake for us because we're talking about data. So Rita Carreon, I am the Vice President for Health at UnidosUS, which is formerly the National Council of La Raza. We're the largest Latino civil rights and advocacy organization based, headquartered in Washington, D.C., but we have a network of over 300 community-based organizations, including community health centers, or FQHCs, that we work with. And we're very happy to have seen it. I think Janice just walked out. Janice Esparzo, that was in our mental health. She's one of our affiliates here in Oklahoma City. First time in Oklahoma City was right before COVID. I was in Mississippi. Yeah. So there's some connection happening here. So I think for us at UnidosUS, data is incredibly important in the work that we do, and I'll talk a little bit more about some of the work that we move forward and some experiences we've had and led.
Excellent. Dr. Hall.
All right, good morning, everybody. Good morning. All right, it's good to always hear the response back. My name is Jeff Hall. I am the Acting Deputy Director for CDC's Office of Health Equity, and thank you for the opportunity to be here, to be able to fellowship, break bread with you, and to discuss data, because being able to create a world where all have fair and just opportunity to be as healthy as possible requires data. You need data to be able to not only understand the needs of those you serve, but to be able to effectively and precisely direct the work, direct the action, direct our hands and our feet towards the concerns and the areas of need that exist in the different populations, places, and settings around the nation. So I'm just happy to be a part of this illustrious group that's here and to be able to have some time with you.
Awesome. Good day, everyone. My name is Brian Rivers. I'm from Morehouse School of Medicine, where our new vision is that we're leading in the creation and advancement of health equity to achieve health justice. And that's new for us, the health justice part, because it really speaks to unmasking and interrogating those structural determinants of health that we know are germane, that often serve as impediments to the advancement of health equity. I serve as the director of the Cancer Health Equity Institute, founded in 2015 upon my arrival to Morehouse School of Medicine. Also, I'm a professor in the Department of Community Health and Preventive Medicine. But more importantly to this discussion, it's been a great discussion thus far, from yesterday intervening with the leaders of tomorrow, to just having these scholarly discussions today about how we can really move things to action. I'm a retired member of the National Advisory Council for the National Institute of Minority Health and Health Disparities, so been at this for a long time. I live in the data world, to your point. I'm a cancer disparities researcher. I've been continuously funded by the National Institutes of Health for the past 20 years to actually do this work. And then more recently, I was a part of the committee that looked at unequal treatment revisited. And that report, as was mentioned this morning, was recently released in June of 2024. So excited to bring some of the highlights from that report to this conversation. Thanks for having me.
Excellent, thank you. You set a really great stage on our first question, really, and that is, how do each of you and each of your institutions define data? Do you want to start us off, Dr. Lee?
Sure. So data is basically representation of phenomena that's taking place either in clinical or community settings. We look at data through a qualitative lens or even a quantitative lens. Qualitative meaning that we're looking for more exploratory data to explain why this phenomena is taking place, either in this community-based setting or in this clinical setting. We look at quantitative data, because it allows us to do some hypothesis testing, because usually with quantitative data, our sample sizes are much larger to allow for generalizability. I don't want to get overly technical and detail in the weeds, but that's how we look at data, both through a mixed method approach. And one is not superior over the other. In areas where there's gaps in the science, then it's good to have a qualitative exploration because it allows us to really examine in depth why this phenomenon is occurring between these two variables or multiple variables. But then and then it helps us generate hypotheses as well. But then the quantitative data allows us to come in and test these hypotheses in a more robust fashion, in a more robust framework, and then offering some type of idea, perhaps around intervention strategies.
Mm-hmm.
So a little less academic definition of it as a CBO, small community-based organization. Our use of data in the Glenn Family Foundation really centers around the fact that data helps us to illuminate and to define the populations that we're really trying to help and serve. Data sort of tells their story. It allows them to have voice and to be a part of the conversation and really communicate what their needs are. Yeah. So data illuminates in that sense. Data helps us to be accountable to those individuals that we're seeking to serve and to provide services for. And it gives us some idea of our impact. We're a small organization, but we certainly hope to have a broad impact and meaningfully impact the lives of those individuals that we're called to serve.
Excellent.
And I'm happy to add, on also the practical lens, aside from the academic, for UnidosUS, data means equity. It means opportunity. It means impact. It provides us an opportunity to be able to make actionable steps to change systems, practices, and investments in the resources that are placed within our communities. For us, data is storytelling. So I really love Dr. Christopher's conversation around the story and how the previous panel also talked about their own stories, and you heard this also in the concurrent. And it's really important for us not only to look at it from the qualitative side, from the surveys and the polling. We've done so much polling, even at the height of the pandemic, when we were not getting information about race and ethnicity data, about where the pandemic was impacting. We knew that it was going to impact our communities the most. So for us, polling was incredibly important for us to be able to get a pulse of what the current beliefs and attitudes and knowledge that our communities were facing. But it also means the importance of having accurate information through direct involvement with communities. And so we also, like I think Bancho was mentioning, we also use the popular methodology theory effect in terms of having listening conversations with our communities.
Excellent. Dr. Hall?
Well, and my comments are gonna really dovetail with what my colleagues have said thus far. I feel like snapping my fingers because data are not these abstract things that just exist out there in the air. Each number, each point of information that you get represents somebody's life, right? And so the work that we do is all about visualization. And so what that means is when we have a conversation about data, we have to be able to think about who is and who is not captured in our surveillance systems, in the many different administrative systems that exist, and what being captured or not captured actually means for the opportunities to be as healthy as possible. So part of what we focus on is how do we transform our system so that the way we are able to serve is attuned to the needs of those many different groups of social populations that exist. Humans create all kind of groups, and we find ways to create cliques and groups and stuff to set ourselves aside. Those cliques that get created, those subgroups that get created, they translate into differences in health and differences in social mobility, for example. So we have to have conversations about data to be able to talk about the impacts of those social phenomena on the way we experience life. And one more thing I'd like to add that is very important to think about when we have this conversation about data is the need to understand setting, place, and context, right? I think that's something that all of us believe in and that we share as an emphasis. Context is so key because one of the things that we in this room all probably knew, but some people became familiar with the fact during the pandemic that the type of job that you work and where you live, those things can determine just how much risk you do or don't experience, particularly as it relates to a communicable disease. We learned a lot and we're able to really socialize people a lot as to just how important where you work is, whether you have a job that allows you to work virtually or if your job allows you to have time at home off if you or your child is sick. So our data concerns have to be able to capture situations and circumstances such as those.
Excellent. Thank you for sharing that. Dr. Glenn, I wanted to jump back to you about what you said around defining populations that we serve. How would you describe the way in which your organization segments data in order to address some of the subgroups that we are trying to reach and trying to serve?
Yeah. So I guess in the sense of segmenting data, we can certainly think of it from an aggregate sense of what data showing the overall picture of the population as a whole. But within that population, obviously there are subgroups as mentioned by Dr. Hall, and we try to define those individuals who have the greatest needs within the whole. Our desire is to address those individuals and to make a difference in the lives of those individuals who may be on the margins, the ones who really don't have a voice, and to assure that the greatest resources are going to those individuals who have the most need. And we put forth a lot of effort and energy to accomplish and to achieve that. I think we've seen a level of success in the area that we've been called to serve.
Excellent. Anyone else want to add to that? The way in which?
Well, I know for me too, this came up when we were having the Q&A for Dr. Christopher's keynote this morning. The conversation about disaggregation is so critical because, again, that goes back to what I said earlier. This idea of who is or is not seen is so very important. We tend to deal with these mega categories. We collapse groups together. For instance, we know in America, ethnicity is dealt with in terms of just one, Hispanic ethnicity. But when we talk about what that means, we know that there are many, many different groups collapsed together who are in the nation and who have contributed to this nation, but that might have come here from a variety of different places. And as a result, have had different experiences, may have different strengths and different needs. And so this idea of being able to subset is in part about understanding that the large categories, Asian, for instance, it's not monolithic, right? When we were in the pandemic, I had to have a conversation when we were doing some stuff focused on COVID, where someone asked me, what is the solution for the Black community? And I was like, what? Because the Black community is not monolithic, right?
Exactly. Yeah.
So this conversation about subsetting is about understanding, based on which area of the nation or the world we choose to focus on, what does the history of the groups there mean for what you may need to do where your health care and your public health services are concerned? How do the differences in experiences and differences with respect to minoritization processes manifest themselves in terms of needs as well as in terms of resources that are available?
And just to build on that, I think, audience segmentation is probably one of the key reasons why we have community-based participatory research methods, right? The importance of hearing from the community and making sure that their voice is represented in the data that you're collecting. And that segmentation often is had when we engage different communities, not treating them as a monolith, right? And so at the end of March, OMB collapsed the racial and ethnic categories once again, so there is no ethnicity. Hispanic is now considered a race, and North African as well as Middle Eastern are added. So very, further complicating our efforts in terms of really trying to collect data that's representative of all individuals, but even those that are disproportionately burdened by sickness and disease, and trying to understand what intervention strategies we need to put forth. So that's the point of engaging communities, because you can learn firsthand from these individuals what needs to happen in this zip code or in this setting, which may not be the same for the neighboring zip code or the neighboring county. And so how we engage a community, the type of information that's extracted from the community, really ensuring that their voices are represented in the data is paramount if we want to really achieve this audience segmentation, realizing that folks aren't a monolith. When I worked in Florida, I had to realize that Hispanics weren't a monolith. I even realized in Florida that Blacks weren't a monolith. And say that, I went out into the community calling folks African American. They were like, oh, I'm Jamaican American, I'm Bahamian. Oh, okay. And it's important because there's so many different cultural attributes in terms of how they socialize, the foods that they eat. And the list goes on how they seek their health care. All of that is embedded in this cultural framework. So it's important for me to understand that this person is from Jamaica, or this person is from Bahamas, or this person is from Ecuador, or this person is from Costa Rica, because then it allows me to go deeper in terms of how I develop those intervention strategies to help hopefully mitigate a lot of the problems that they're encountering as it relates to health-seeking behavior.
And it brings into focus what I stated earlier in regards to just accountability with the data. How do you use that data to really address the issues of the subgroups within the population itself? One of the things that characterizes us in the Mississippi Delta is that we've been studied extensively. There's probably some of you who have written books and papers and you've referenced us, I'm sure, somewhere. Right, and we're still studied even to this day. And to a degree, and one of the things that we tend to react to is the notion that we have been utilized to help define, or we're a control group for different entities, what have you. But that does not necessarily translate into impact or change. You know, some of the same problems that have plagued the Mississippi Delta for the last 50 years are still there. We're still number one in hypertension and various types of cancer, kidney disease, diabetes, obesity, and all that comes as a result of that. So the dial hadn't really moved, but there's been much data collected on us, but it hasn't really translated into meaningful upward mobility and change in life for people in that area.
Yeah, and I want to add to what Brian had said about what happened earlier this year with OMB, actually having Hispanic, Latino considered or at least categorized into the race ethnicity instead of having the separate question, because there's always this attempt to try to put people into boxes and check this box and that. And, you know, I know my boss always says, well, you know, for us Latinos, you know, we're more likely to marry out of our race. And so pretty much kind of we love everyone. What does that look like? I know my child is not just Mexican, he's Polish and Italian. So this whole sense of where, you know, the intersectionality that we're not necessarily talking a lot about, and we can be studied as much as possible, but being able to go and talk to the community and have conversations about how they themselves self-identify is critically important. But it's even beyond just race and ethnicity or language or religion or any other demographics. It's also around what we are being encountered with misinformation and data that, you know, and you're seeing it during these elections, but you saw it at the height of COVID and continued to see it in public health, the misinformation of data that people just believe, whether it's on social media, and what are the sources that you're getting. And I know the next panel will talk about AI, but I think it is critical for us to kind of look at data in a different way, and not just on the quantitative what's on paper, but getting out of our own space to be in community.
Rita, I want to stay with you, and I want you to talk a little bit more about some of the solutions your organization has created and implemented in order to kind of change the narrative a bit and also have true impact.
Yeah, no, I'm happy to do that. I think Unidos has been in this road for a long time advocating for disaggregation, but also for the privacy and safety of the data and how the data is being collected, but also how it's being used for our communities. And I think across the board, we've all been involved to some extent with the All of Us research program, which is an NIH funded initiative, where we were very intentional about how are we going to use this information, and the involvement of the community and the users, that it's not just researchers and practitioners, but also community. For us, we also have learned that it is important for that data to also belong in the community. It belongs to the community. It doesn't belong to us. You know, one thing that we've been working with, and we're part of coalitions, we're part of, you know, advancing the importance of collecting this information. I know with Julia Choi, with the Asian Pacific Islander, led an RWJ-funded effort across multiple organizations, NUL and other organizations to even try to get MENA into the OMB and across different states. But in regards to our current work that we've been doing and some of the solutions that we've been doing, it's a very multi-dimensional approach of how we use the information and data and how do we develop the interventions that we're doing. I'm very proud to say that our Esperanza Hope for All campaign, or our initiative, which is what we call our EFA program, was established first as our Esperanza Hope Fund during the pandemic because we knew that our community-based organizations were going to be the first ones where our community is going to knock on their door. So being able to then just fund them, no questions asked, give them the cash, so then they can give the cash in the parking lots, give the food, give the diapers, be able to give support for our communities, and then the evolution of that into mitigating the impact of COVID, not only on health, but on education and our economic well-being. And so we've been at it for the last 4 or 5 years, and I can talk a little bit more. I don't know if at this point in time you want me to mention some of the efforts that we've been doing. Over the last 4 years, we've been in multiple coalitions, but we've also worked with our community-based organizations. UnidosUS is part of 300 community-based, a network of community-based organizations and health centers that I mentioned earlier. And they were out addressing misinformation, because when we might find that data, we're talking to the promotores de salud, the community health workers, and they're saying, well, there's a solution, a bottle of solution that people are injecting in themselves that's going to protect them from COVID. And so some of this information is trying to say, hey, this is what the research is saying. Here's where the vaccine is coming into play for us. We were able to address misinformation, disinformation. We were able to do what we were calling an air game and a ground game. Our air game was social media, national influencer, kind of assessing what the layers looked like, and being able to push out messaging. And then the ground game was in community, working and funding our community-based organizations for them to be able to establish vaccination sites. We established more than 1,000 vaccination sites. We reached about 24 million individuals in terms of messaging. In the last 3.5, almost 4 years, we've been able, and we, meaning our community-based organizations, have been able to vaccinate over 700,000 COVID vaccines as well as flu shots. We continue to do some of this in terms of just being the trusted messengers. I find that initiative probably one of the most successful efforts for us when we see the disparity closing at the first point in time when we were all, do we all remember the days when we got our first vaccine and then our second vaccine? Now we're at number 6, I think, or 7 booster. But I think being able to add those resources and give the power to our communities, which they themselves already have, but stepping aside for them to be able to make those movements was powerful. And I think we need to continue to do some of that. We're still doing some of it with our NIH SEAL Alliance that I'm part of the community co-chairing steering committee, where researchers are also working with community-based organizations. I know Morehouse is part of that effort as well. And so those are important. There's a lot of lessons learned over the last couple of years. And if we don't talk about some of those lessons and try to institute them into practices and policies, then all that efforts and evenings and working and just and everyone who passed and transitioned from this world would be without, why we're here. So I think we need to be able to continue that pulse.
Excellent. I wanted to kind of shift it to CDC and their standpoint on the many different partnerships that you have. How would you say those programs, those initiatives have made true impact using the data and the relationships that you have been able to build to address health equity?
Yeah, I think there are many different examples that could probably be discussed here. Some of the sessions have already touched on like some of the major instruments that have been used. I remember one of the presenters in the session that I went to, the health equity focus section, Dr. Pope was talking about 2103. And I started smiling from ear to ear, because that is one of those programs that we were fortunate enough, we're blessed enough to be able to participate in the development of and the assistance with from our agency. And during the time where there was a real need to be able to get resources out into the spaces locally. That particular opportunity, the instrument that it came to sit atop of, allow a number of different interventions to be done in ways that wouldn't have been possible if those funds couldn't have flowed forth through that particular grant instrument. And also too, which is one of the focuses of the conversation that we're having, you can have funds, but if the flow of the relationships, of the capital that's social in nature isn't where it needs to be, then we know that those funds won't reach the folks that need in the greatest amount. And so instruments like 2103, for example, were the basis for a variety of different groups, health departments in combinations with CBOs, and many, many other different types of entities, faith-based organizations, opportunities for all of those different actors and entities to come together to be able to serve their local communities were provided. There are a number of other specific types of partnership instruments that also come to mind for me. For example, there were instruments that came out of our National Center for Immunization and Respiratory Diseases that allowed funds to flow into some of the partners. I don't, we say non-traditional partners. That term to me has grown because some of the groups we call non-traditional, they've been in the room, but I do realize too there are some additional new groups that have emerged out of need that became possible to reach, right? Some of the innovative instruments that came out of that particular center allowed new combinations of coalitions to be created in ways where the vaccine hesitancy emphasis was to be approached not just through some formula that our agency happened to hand down. What we hand down is not going to translate, right? It has to be real, it has to resonate, and it has to be something that people in local circumstances are going to trust and going to naturally relate to. So we have an array of many different examples of local partnership where the needs drove the way the work happened flexibly as a result of what was possible because of what the pandemic allowed. And hopefully some of what was allowed to be created, some of the infrastructure that was generated is going to continue. One of the things I also am sensitive to, this was just mentioned, right? The grants that we create, they don't last forever. But what we hope to be the case is that the relationships will. And one of the things we are interested in is figuring out beyond emergency circumstances, how do we figure out how the resources continue to be invested so that we don't have to create new mechanisms when the disasters happen. If we are able to be there constantly, we won't have to run to do things that aren't being done when we have the need arise.
I think that's a great segue into my last question before we open it up to the audience, is that can you share, each of you, can you share a little bit about any tips or resources that can help strengthen partnerships in communities that really need our services and our support? Dr. Glenn?
Sure. As the only CBO on the stage, let me say to Dr. Hall, keep the flow coming.
We're trying.
Faucet off.
It ain't easy, but we're trying.
Yeah, we want you to keep the flow. But I guess our story with data is kind of interesting evolution. When we started our Family Foundation 10 years ago, when we started our Family Foundation 10 years ago, and our first, I guess, community effort was to provide food for children during the summer months. And it was really just an outgrowth of what our mother and father did. We had these huge gardens every year that we hated working in, and we were growing vegetables, seemed like, for the entire community, because my mother would give away vegetables throughout the year, cook for people, et cetera, et cetera. So we just kind of did what we knew, but we quickly found out that our garden wasn't big enough, and that we needed resources from others in order to really continue and to be impactful with that work. So data became something that we started to pay attention to, and keeping up with numbers and collecting data along the way so that we could engage entities like the Mississippi Food Network and eventually provide even more resources to the community. So for instance, one of our programs that we have is a weekend meal program. It started during COVID, where we noted that once the schools closed, there were a number of children throughout our communities that were not getting a meal during the day. We started to provide food for those children once the schools came on board and started to provide meals during the weekdays. We noted that a lot of kids didn't have food over the weekend. So we started a backpack meal program to address those food insecurities over the weekend. And those programs are yet in place today. And in one particular community, we provide about 400 children with backpack meals over the course of the weekend. I say all of that to say that there are many needs, and certainly any number of ways that we can address those particular needs, but that's just one of the things that the Glenn Family Foundation does in order to be impactful and meaningful in the community.
Thank you.
So I have a list, but
I got a list too now. I can share more.
but I think, I'm growing more and more into this space that I truly believe that without representation and our voice, things won't happen. And we have to institute it into our practices, our policies, and investments. So my lens is advocacy and also the engagement of civic opportunity, right, for our communities. And thank you for the work that you're doing in feeding the line. How do we shorten the line? But how do we end the line, right?
Yeah.
And a lot of the work that we've been working on and kind of really trying to evolve into systems changes, if we don't have representation at the table where there is decision making, and that centers our communities, then we're going to be left behind. There is, I started writing, encourage federal agencies, but I'm like, if not require federal agencies when they write their RFPs to ensure that research institutions, providers, whatever, are able to include or have the inclusion of community-based organizations because they have proven themselves time and time again. Multi-year funding is critical, planning. And when I also say federal agencies, I also mean any funder that has the power. So that can be corporations, foundations. These are important elements for us to be able to do that. I was very inspired by Praxis Project, Buncho, with his ability to be able to provide capacity with community-based organizations. Our CBOs need training and technical assistance on how to even apply for a grant. Whether it be a federal grant because of all the administrative loops that you have to go through, but then at the same time, being able to be a good writer and have the metrics and ability to do that. And then I think it's critically important to co-create our programming, to make sure that the data is owned by communities and being able to have shared decision making. You're seeing that in the NIH SEAL Alliance, where our community members are co-principal investigators. They're sharing that voice, that power, and that decision. It's not just researchers in the space. Increasing the indirect cost. Everybody in finance will know that this is not enough. 10% is not enough. Foundations, some of them have gone from 7% that have now are at equitable lens to 20. Great. But even the SEAL Alliance has also increased their IDCs. And so I think it is important because we have to maintain a business, meaning administrative and operating costs, to be able to feed the line. And then lastly, I would say always lead and move at the speed of trust. And that's something that I've learned from, and we know who that doctor is at NIH. And it is around being authentic with your voice and being intentional about having that equitable lens in every place that you have the privilege to speak, but also be in the room with.
Excellent. Dr. Hall?
So I'm going to try to keep mine concise, which is hard.
Oh, sorry about that.
No, I'm speaking about myself. I got a big mouth, so I'm going to try to keep mine concise. But I would emphasize two things. We start with the community. So when it comes to like the data, and when we think about the data partnership, I would like to advise that we remain flexible with what that is, because data don't have to be these things that exist out there in the space somewhere. How we start the conversation about data, I think really determines how people like come to us and how they are willing to co-lead with us. And so one of my passions and one of the things I hope we will have the opportunity to continue to nurture and grow is community-centered and community-driven public health surveillance, right? And what that means is being able to come up with a model of having robust data be collected, but making sure that the data elements that are in there, the representations that come out, the interpretations, as well as the practical applications, guess what? They don't reflect what somebody outside the community like me wants. They reflect what it is that is going to be real, what it is that is a concern to the people they're intended to serve. So I would encourage us to be able to enter the conversation on data, not where we are from, but from where people are, so that the way we think about what could be considered to be data, the experiences that could drive the data collection process are really allowed to be optimal. Secondly, in addition to the community-driven and the community really sort of informed surveillance process, I am a longstanding believer in and champion of practice-based health equity research, right? We need evidence in order to be able to do what it is that we have to do, right? But that doesn't mean that if it's not a clinical trial, that it shouldn't be done. Sometimes people get caught in some of the binaries that can come to exist where certain classes of data are concerned, and I'm not knocking that either. We do need robust data. We do need some of that. But that doesn't mean what you do in terms of dealing with things through trial and error, if approached rigorously, doesn't have value. You know, I had the opportunity to release a supplement earlier this summer that took me 3 years, and I was like, I'm glad to have this done, right? But that particular supplement is all about how people had to basically adapt in the face of COVID, in the face of hurricanes, in the face of flu, in the face of social unrest due to us having a reckoning with structural racism in this society. And if you think about all of that happening at the same time, it equates to having to do your best, bring your best, and have good data be collected and released in conditions that are going to be suboptimal, right? We don't have to be perfect, right? But what we do have to do is strive to bring every single ounce of experience to the table on behalf of those that we serve.
Excellent. Thank you.
And then just building on, all of the comments that my colleagues have already made. In sum, data equal dollars. And I wish we had infinite resources available to us to handle the complexities of the problems we see in society. But we know that there's a finite amount of resources. And so it's incumbent upon us in this room to continue to raise our voice and advocate for more resources. Before any NOFO is released from the National Institutes of Health, they have to go through a process of RFI. How many have ever participated in an RFI, a request for information? Yeah. And this is the time for the public to come in and weigh in on how their taxpayer dollars are being allocated by this federal agency. Because that's basically what their budget, how their budget is comprised, through taxpayer dollars. And so we have to continue to raise our voice and create capacity, making sure that the funds that are allocated through our federal agencies are indeed creating capacity for us. Just as a couple of examples, NIH has been really in tune to the role of community, even post-pandemic. They were prior to. You had the Community Networks Program through NCI. You had the REACH program at the CDC, the Prevention Research Centers. Phenomenal networks, but they were underutilized during the pandemic. A hub and spoke model would have been great to get the information out to communities. So we have to help them actualize that. And so in the last 3 years, NIH has been extremely responsive. There's been a Compass initiative that has been released that actually funds community-based organizations directly, keeping the money out of academia, because some academic institutions have IDCs or indirect costs or rates up to 80%. So if the grant is $1 million, 1.8 million is written to the institution, and 800,000 off the top goes to the institution in terms of unrestricted dollars. So NIH is getting savvy because they're hearing from people like you in terms of how to better spend these finite resources. There's another initiative that has recently been released by the NIH director called CARES, where they're, again, funding community-based organizations and that are partnering with primary care clinics to help foster primary care. Because we know primary care is where it all begins. If you don't have a primary care provider, then you're dead in the water already. And then other initiatives such as persistent poverty. So we talk real globally about a lot of these societal factors, and we know that they're impacting health outcomes. But how? Do we really know how these social determinants of health are really impacting? What are the mechanisms of action or the pathways to adverse health outcomes? Not all social determinants of health are bad. It's those adverse social determinants of health that we need to interrogate and study more. And so NIH recently released an initiative called Persistent Poverty, studying individuals who have lived in a poverty-stricken community for over 3 generations. And how can you mitigate the fact? So all that to say that we got to take the onus off of collecting data just at the individual level. But if we really want to attenuate to health justice and deal with these structural determinants of health around racism, around discrimination, about poor policies within the health system, because healthcare is localized. Most folks are not treated in DC and Congress like the Congress folks are at Walter Reed. They're treated right in their own neighborhoods. And most health systems have a community health needs assessment that they have to produce every 3 years to remain, to be in compliance as it relates to community benefit reporting. And we use that in a very unique way because that basically is our formative research that tells us what needs to happen in this community. And then we develop community-led interventions, from Barbers Against Prostate Cancer to Beauticians Against Breast Cancer to Fishers of Men, where we're engaging faith-based organizations, trusted entities. We're building capacity. We're leveraging the grant funding and putting it right into the community. We did that during COVID in Albany. Early on in the pandemic, Albany was a site for excessive mortality due to COVID. So we went down, looked at the community health needs assessment, saw where some of the linkages needed to happen. And so we leveraged about 100,000 via supplement from NIH. And we put the entire 100,000 down in Albany, a 30-county catchment area. We funded 10 faith-based organizations to train 2 church health advocates to then liaise with the local health system to be that linkage, to help provide information, to help overcome different social impediments that they were encountering. Again, creating this capacity, empowering it, and putting the money in the community where they know what to do with it. So we really try and foster community-led interventions, really focused on community empowerment. Not this academic model where, we sort of put you on a community advisory board and give you a lunch and we give you a couple of dollars and like, all right, we got the community perspective. No, we empower the community in a real way. That they can go back, and do what they need to do in their community without me, the technician. I'm just here to advise and guide from a technical aspect to make sure the money keeps flowing. But ultimately, at the end of the day, you own your intervention. You own what needs to happen in your respective community. So we got to continue to generate data beyond the individual level, though. Yeah. What are the policies and laws within this health system that's impeding the delivery of adequate health care? And that's something we don't interrogate enough. A lot of folks just focus on, patient-reported outcomes. We're past that phase. We did that. Pandemic amplified that. Hey, we've made no progress related to health equity. And we highlighted that in the unequal treatment report as well. We have to begin to deal with the societal factors and their influence on the health system, but then ultimately on health outcomes. It's not an easy task. It's very complicated. It's very political in scope and nature, but we have to tackle that elephant in the room.
Yeah, thank you. Can we give our panelists a round of applause? Excellent. We are pressed for time, but we do have time for just a couple of questions. I know that a microphone will be going around I see several hands, so hopefully we can get. There's one here, two here.
Row.
Oh,
Go ahead. Okay. Good afternoon, Joy D. Calloway with the National Medical Association. I know we have all been trained to expect the best, prepare for the worst. I'm interested in what particular strategies you all have considered to flip the switch if, God forbid, November 5th goes the way of those who want to further marginalized communities.
So I think first and foremost, we have to deal with our lexicon and how we describe these events that are occurring in our community. I'm in Georgia, so they didn't expand Medicaid, of course, and you continuously see the southern states in its lowest tier as relates to poor health outcomes. That's systemic. It's nothing that I'm doing on my own volition, but it's a structure of society that I live in. It's not an act of randomness that from Louisiana, Mississippi, Alabama, Georgia, and the Carolinas continuously are in this lower tier in terms of health outcomes. That's systemic. I'm not gonna go and develop an intervention and change your knowledge, attitudes, and get you connected and get you screened early. It's bigger than that. And we have to start talking about that through a scientific lens. Diversity, equity, inclusion there's a scientific basis to that approach. When a system or organism is more diverse, it's just better on all fronts, across all sectors. But we allow for the politicalization of these terms without saying equally as loud the scientific basis that help inform this approach. So when we talk about diversity, when we talk about equity, when we talk about inclusion, when we talk about advancing health equity, when we talk about health justice, there's a scientific basis that we have to come from. And that scientific basis is rooted in what? Data. Who can refute data? And that's what we have to change. Whoever's in the office, data doesn't lie. And again, we may be sequestered or squandered or suppressed at the congressional level, but there's so many other levels that we can impact. At the state level, no folks should know you in your state house, but even more so your city council. They should know you at your city council. The mayor should have a task force. You know what's going on with your constituents in your area? And you got to put the data in front of them and let them see and then hold them accountable. Right now, all the politicians are running through the churches. No. If you want to speak in this microphone, you about to sign this MOA, this Memorandum of Understanding, and you will be back regardless of the outcome of the election. You will be back, and we will hold you accountable. Otherwise, stop pimping us. Don't come in here for a vote, and you're not willing to vote for me on a larger scale. And that's the type of conversations we got to have, data-driven. This is all data, science-based policy. That's what we're advocating for. We're not advocating for something that we're full of emotion and passion about. We are passionate, of course, but there's a scientific basis rooted in data. And this started way back in the HEiA report in 1985. And this was during Reagan administration. Then Secretary of Health, Margaret Heckler, commissioned this report, and it showed the excessive Black and brown deaths in the United States in 1985. And we're still having this conversation 30 years later. It's systemic. And we got to begin to dismantle it accordingly. I'll stop there.
Thank you. Anyone else want to add? All right.
Hi. Yes, I'm Jackie Burton, the president of the Conference of National Black Churches. I thank all of the panelists. Dr. Hall, I don't want you to think that I was flirting with you, but see, the Conference of National Black Churches received substantial support from CDC to. Alrighty, I'm back now. I was not flirting with you, but I could do that. However, let me just simply say, no, the Conference of National Black Churches received substantial support from CDC for vaccine, advancing the vaccine. We did over 4 million vaccines through our 30,000 congregations. So I was raised to say, if you love me, don't keep it a secret. I just want everyone to know that everything he said about CDC is true. I do hope that the money will keep coming, but we wanted to thank you for that on behalf of all of our churches. Thank you.
That's awesome.
No, thank you, thank you. We appreciate that.
One last question.
Yeah, two.
Hi, thank all of you for the passion and the work that you do representing your communities in a good way. I'm here representing indigenous communities, and right now data sovereignty is a big deal for us because of the misuse of the data from various universities and things of that nature. And now we have, most of our tribes have IRBs as a result of the Markow effect at Arizona State University, which I'm a graduate of, but she misused blood samples. Data sovereignty for your communities, have you ever had to sue the federal government and the universities that have misused your data in past situations? Because data sovereignty now we don't trust as a result, and we're missing out on getting that data to impact regulation and law. So have you experienced any of that in your communities?
Great question.
So I reside in the southern U.S. corridor. We have a partnership funded through the National Cancer Institute with UAB O'Neill Comprehensive Cancer Center and Tuskegee University. And as we attempt to restore relationships in Macon and Bullock counties, where the tragedy happened in the syphilis study that took place at Tuskegee, realizing that the principal investigators were not at Tuskegee, but they're actually from another institution. That's not told loud enough, because they're thinking it's black investigators who went out and just exploited these individuals who are just willy-nilly walking around with syphilis. There's still something that needs to be unpacked about that. Were they given syphilis or what? And so these atrocities, these abuses are known. And how we address them, I think you guys have really established a great model. I was at NASM about 2 months ago, and they were talking about this data sovereignty and data stewardship and having an agreement with, you cannot touch my data unless I give you permission to. And I think you, the indigenous populations here in this country are setting a very unique precedent that others are really looking to follow, especially as we move into models of precision medicine and precision prevention that entails the interrogation of folks' genome. And how that information, like Blackstone and all these other outfits that are trying to buy 23andMe and Color Genomics, and what are they going to do with this data? Just build robots, or is there some other design to utilize this data to, inform other algorithms? So we got to have these protections in place, because otherwise we'll be, here having this conversation 30 or 40 years from now, because it will break down trust, and more importantly, trustworthiness of the research enterprise. And so data sharing agreements is paramount. We discussed that with community members even before we even write the grant, of how this data will be used, who will own it. If I gave any biospecimen to this biorepository, what are my rights to it once I give it over? Whether it's saliva, whether it's urine, whether it's blood, who has the rights to interrogate it? Because another issue we are still dealing with the effects of is the Henrietta Lacks debacle, right? And the information not being shared with the family, but everyone's benefiting from the discoveries that were made. And so you gotta have these protections in place. And that's, again, how we, the power of how we conduct research and the regulatory and the protections that we put in place early on, not at the end.
Yeah, excellent.
Yeah, I was teasing Brian, like I'm just going to say, what he said, right? Or he was actually going to say what I said. But now I'm saying what Brian said. And I think there is, we can learn a lot from the data sovereignty effort that the Native American community is doing. We've had the privilege of being able to listen to some of that during our NIH and SEAL Alliance, and it's incredible. I think every community has been impacted by collection of data by the federal government and in treatment and that has been detrimental to our community. We can talk about Henrietta Lacks, but we can also talk about hysterectomies happening in Puerto Rico, and even to this day in migrant camps also happening. So those that are voiceless that are also, we're not getting that information and stuff and utilizing that. So I think that we need to be out in the allyship with our partners to be able to showcase the importance of data sovereignty.
And I concur with what my colleagues have said. We actually need individuals like yourself to keep our feet to the fire, right?
Yep.
You know, a lot of times people hate to be put on the spot. We have to be put on the spot, right?
Absolutely.
And I don't mean just individuals like me that might pop up in the room. There has to be systemic pressure, so that like the principles like that we have lip service to as it relates to sovereignty become actual parts of the culture and the actual little p operational policies of the agency. And so when we have individuals that actually raise issues about things like what you mentioned, it is productive, it is helpful, and it is very much necessary to ensure that not only do we learn from the missteps and mistakes of the past, but that we really true, not just with the rhetoric, but with the rules and the relationships, move towards a truly more data equitable future.
As the again, the lone CBO on the stage, we are fiercely protective of our data. We have been victimized.
Yeah, especially.
And there are data thieves out there, just so you know, and we've been victimized by that, so we're fiercely protective of that at this point, and we too do everything that we can to assure that we have relationships that are open and upfront from the beginning with some of the research that we're doing as a small family foundation as well.
Excellent. Well, I know that we are preventing you from eating your lunch, so we'll wrap it here. Thank you all for your questions. Thank you to the panelists for your great insight and nuggets. And I hope all of you have taken something that could be actionable as you go back to your communities and continue the great work that you're doing. Thank you again and enjoy the rest of the summit.